on November 3rd, infant and toddler feeding challenges, how to empower families. We are delighted to have Jessica Schwab and Lauren Pacilio from Fairfax. Lauren, I hope I didn't just botch your last name, but we are delighted to have them sharing their expertise, opportunity to hear them present at Creating Connections to Shining Stars. And I thought their information was just so valuable, so we're delighted to have them joining us. And as if you are just connecting, you will have heard us talking a little bit. They are having some technology challenges in Fairfax, so we really appreciate their flexibility. They put a lot of work into this, and I know this is going to be fabulous, and we'll make a go of it. So Jeff and Lauren, I'm going to turn it over to you.
Thank you. This is Lauren, and we're going to start out today's presentation with some true or false questions. So the slide should be on slide 9, true or false. And what we'd like you to do is use your writing tool and make an X or a circle or some sort of mark in the appropriate true or false box for each question. So I'm just going to read them out loud. So the first question, true or false? As the interventionist, I have to be the one feeding the child in order to provide feeding therapy. True or false? The child has to eat in order to participate in the feeding therapy session. And true or false? As the interventionist, I cannot coach the parent during a feeding therapy session.
And Jess and Lauren, you've got lots of good responses, and all of them as of right now, all of them are marked as false.
Fabulous, because that is exactly correct. As the interventionist, we actually want to support the family and the caregivers in feeding the child if that's what's happening. So that leads into our second question of, does the child have to eat in order to participate? And we believe the answer to that is no, that there's lots of ways for children to learn and participate without actually eating anything during the visit. And finally, as the interventionist, you actually really want to coach the parent and empower them to learn the skills and support their child to be successful during meals. All right, we're going to move on to the next slide and talk about some of the red flags for feeding concerns that we want to identify and support our families through. These might be things that service coordinators are picking up on their initial visits out with the family, or it might be something that you as a provider notice as you're working with the family, maybe on a child who came in at a very young age. One of the biggest red flags for feeding concerns is poor weight gain, or children who are quote-unquote falling off the curve, and that's the growth curve that their pediatricians will be plotting them on. We also want to take into account parent reports of mealtime stressors. And parent input is really important in early intervention. They are going to be the ones who give you the best information about their child. Parents will also may report challenging mealtime behavior, such as tantruming, throwing food, refusing to eat, or not even sitting in their chair. Next slide. Lack of progression through food textures is also a concern. So this might be your kiddo who's really having difficulty transitioning from smooth purees to a chunky puree, or having difficulty transitioning from soft solids to firmer solids that require more chewing. And similarly, children who are having difficulty transitioning for drinking, so from a breast to a bottle or from a bottle to a cup. And finally, we want to flag those kids who really accept a limited variety of foods. These might be the kids that eat only dry, crunchy foods, like chips and puffs and crackers, or the children who eat only certain colors of foods. We want to really be aware of that. Next page. So in this page, you should be looking at a picture of a child who's in a neonatal intensive care unit. And we really want to pay attention to kids' medical histories as we're considering feeding as a concern for them. And some of the things that are often significant for children with feeding issues are their history of prematurity, cardiac issues, respiratory issues, gastrointestinal concerns, reflux, muscle weakness, craniofacial differences such as clefts, sleep difficulties, and food allergies. All of these things are things that immediately in my brain flag that we need to ask some more questions about how the child's feeding is going. And we also know that poor feeding can have a negative impact on multiple areas of development, including things such as sleep patterns, socialization, and communication. Next page. So now we're going to discuss the role of the early interventionist in feeding and what you can do as a home visitor to support the family. The first thing you want to do is review the information from the medical team with the family. You might be looking at NICU discharges, video swallow study reports. This is important so that you can identify what the family knows and understands, which might be different from what the medical team thinks the family knows and understands. You want to help the family identify any changes in their child's status that might indicate a need for further medical follow-up. Maybe they weren't aspirating, but now you're noticing coughing and choking while they're drinking, and it might be time to go back and see the doctor. You also want to support the family in their communications with the medical team. So, helping them figure out what they want to say to the doctor, what cues, signs and symptoms do they need to identify that will support those productive conversations with their doctors. And finally, you want to help the family identify any barriers that they may have to follow through with the recommendations from the medical team. And these could be things like childcare with other siblings, transportation, income, and communication barriers such as languages. Next page. As the early interventionist, you also want to support the parent's ability to carry out the recommendations that are made by the medical team. And these could include things such as changing feeding schedules, making changes to whether or not the child is fed by mouth or if they're using a supplemental means of nutrition such as a tube. And if they are, maybe you're changing the amount that you're offering by mouth or through a tube. You want to support them in changing the volumes and textures of foods that are offered as recommended by their medical team. You may help them identify appropriate positions. Maybe their child needs to be seated more upright or in a sideline position to support their feeding. And you also want to help them if they need to make any changes to mixing formulas. We often see children who are whose formula is mixed to be more calorically dense, and you want to make sure that they're mixing that appropriately so that the child gets the maximum benefit from their formula. Next page. So now you should be looking at a picture of a family having a meal, and we'd like to use the chat at this point and have you guys share with us what interactions and routines that you can identify within this picture that really support a positive mealtime experience for this family.
And Lauren and Jess, as they're starting to try to read some of those chat responses. They're all gathered together, the parents and the children. They're all eating the same foods, and they're shared foods. The father is looking at the children. The dad's helping the younger child. They're sitting together, eating the same foods and talking and communicating together. Let's see if I missed any others. There's good interactions. They're following instructions to prepare the foods. The older children are serving as models for the younger children.
Great. And those are some really fantastic responses, and I think you've identified a lot of the things that we were hoping that you would identify in this picture. The family's all sitting together, they're eating the same food. The interaction is really key in this picture, and that's something that we're going to talk about next, is how the parent-child relationship really supports feeding development. So we're going to move on to the next slide. So let's talk about some of the benefits and supports of providing feeding intervention in the home. So the first benefit and support is that you're doing it in the home. The child is being offered food in a familiar environment. by familiar people during their typical routines, and ideally during their typical meal times. In the home environment, you can really focus on relationship-based intervention and supporting the relationship not only between the parent and the child, but developing the relationship between you as the interventionist and the parent, because we know that's just as important. And since you're really there as the coach, your relationship with the parent is key here, as opposed to maybe your relationship with the child. And also in the home, the caregivers are feeding the child, which allows generalization of the skills that you're teaching to occur more naturally. Next slide. Working in the home environment also allows concerns to be shared more openly. I think a lot of our families are dealing with a lot of emotions when they have children who aren't eating well or who may have other developmental concerns, and I think it can be difficult for them to share those concerns with us, and they may feel more comfortable doing that in their home as opposed to in an office. You can identify, share, and support cultural differences around mealtimes more readily in the home. In the picture 2 slides ago of the family sitting on the floor, that's very different from the way that I grew up eating, but if I can see that and participate in that routine, I'm going to be better able to support that family. In the home, you're also using a transdisciplinary approach, meaning that all adults, including other service providers, if there are other interventionists working with the family, can learn and are encouraged to use the strategies that are identified and practiced during their visits. Home visits also support educational and medical collaboration. A practitioner in the home can gather information and share with the medical team, or support the family to share with the medical team about what's actually happening. And finally, for our parents who are breastfeeding or hoping to breastfeed, breastfeeding is more naturally supported in the home environment. Next slide. So let's talk a little bit about coaching and early intervention and feeding within family routines. So we know that mealtime routines can occur across a variety of different locations, and often may vary based on the specific routine day to day. You know, a snack might be in the car on the way to soccer practice for a sibling. They might be having dinner at a grandparent's home or out at a restaurant. So you want to help the family identify their own unique mealtime routines. What are the things that they do that make mealtime either work the way that they want it to, or maybe some of the things that they would like support with. And you can also examine and help identify differences between the mealtime routines at home and those at child care, if the child attends a child care. I think we hear a lot from families that my child eats at daycare, and why don't they eat at home? And that's something that we can help them with. I often go to daycares for the children that I'm seeing for feeding concerns so that I can do some observation and help the families and the daycare providers problem solve together. Next slide. So we're going to use the chat feature again, and what we'd like to know is your thoughts on some other parts of the mealtime routine that do not require the child to eat. What else could the child do to participate in the family's mealtime routines?
Barbara says setting the table, selecting the foods and preparing the foods. Kay Hansen says playing with the food, hand washing, preparing your meal or your plate, cleaning up, saying grace, helping with shopping for meals, I think. Cleaning up after the meal. Let's see if there are other ones. Setting the table. Select the foods.
Okay, great. Yeah, those are some really great ideas. I really like the idea of shopping. That was one that we hadn't identified, but I actually do talk about that with families all the time. What a great way to have maybe a slightly older child be invested in the meal if they've helped select foods and gone to the grocery store and picked out the apples or picked out the oranges. Yes, all of those things are fantastic ways to help a family help a child participate. And I think these are the things that we can really help the families identify as still part of their routine, but maybe the one that doesn't involve eating. We're going to move to the next slide. So when you're working in the home environment, as an interventionist, you can observe the family's routine as typically as possible and then join in to support their outcomes and their goals. The strategies that you provide are then going to be individualized to that family, and you can give them feedback in that moment. For example, you can coach them to try a different food or maybe a different presentation of that food, trying a different utensil, or changing positioning. And by doing this in the home and in real time with the family, you're decreasing the competing demands that often happen around mealtimes, such as establishing a new routine on their own without support. And those decreased demands really support the family's ability to learn the strategy and then implement it on their own. Next slide. So let's talk a little bit about the feeding relationship. Because we really believe that the primary goal of feeding intervention is to support the parent's ability to read the child's cues. Children provide cues regarding timing, volume, preferences for foods, pacing of how the parents are offering the foods, and their overall eating capabilities. We know that children eat best when their parents recognize and respond appropriately to their needs. For example, letting a baby decide when he's done eating. Maybe he hasn't finished the full 4 ounces, but if he's indicating that he's done, respecting that. Or, for example, waiting for the child's attention to be directed back to a spoon before offering it again. Using the picture above as an example here, this baby is looking at the spoon but not really looking at his mother, cueing her that he's ready for the next bite. This allows the child to set the tempo of how the meal is going to go. Next slide. We know that children who are designated as at risk for growth have families who may increase their attempts to promote food intake. These parents are usually very worried about their child's development. They may be told that maybe your baby can't have this surgery that they desperately need until they weigh a certain amount. And so the parents then increase their attempts to get their baby to eat. These attempts interfere with the child's desire for independence and control during a meal. And we do know that mothers of low birth weight children tend to be more active in feeding. They don't always read the cues as consistently, such as closing their mouth or looking away. And this results in overall decreased volume intake, possibly due to the time and energy of the activities and the attempts of these parents. Next page. So children with feed, oh, sorry, I forgot to do the chat. So we're going to do a chat real quick, and I'd like you to take a look at this picture and tell me what you think is going really well in this picture. What do you think is supporting this mother and this child's feeding interaction?
There's touch happening. Both are calm and engaged. Closeness, the nurturing, the baby is engaged. Barbara says he's participating in holding the bottle with his mother's help.
Yes, absolutely. Those are all of the things that we were hoping you would identify here. So this appears to be a fairly successful parent-child interaction around feeding. Mom is looking at the baby, she's providing a calming touch to his head and supporting him in learning to hold the bottle on his own. In this particular picture, he's not looking at his mom in that moment, but that could just be a positioning difference. So one of the things we know about children with feeding disorders is that they are more likely to have developmental, emotional, and behavioral disorders. But when caregivers are consistently responsive and sensitive, children develop better social emotional development, have improved learning and cognitive skills, and have fewer illnesses. So feeding really serves as a foundation for bonding and attachment and the child's ability to safely develop autonomy within that parent-child relationship. Next slide. So parents of children who have eating difficulties are more likely to use coercive strategies to get their child to eat. And these could be things like negative verbal prompts during the meal, maybe threatening, you can't have your dessert until you eat your broccoli. Maybe some negative physical contact, like removing the child from the family meal if they're not cooperating in the way that the parent would like them to, or making negative comments about the meal. These strategies tend to lead to a persistence of feeding problems and an increase in disruptive behaviors during mealtime, and actually may increase the child's distaste for the specific foods that are being offered in that moment. Next slide. So knowing that 25% of American children demonstrate some form of feeding disorder or concern at some point during their development, and 80% of children with developmental delays demonstrate some type of feeding difficulty or disorder at some point in their development, the positive benefits that we discussed on the previous page, such as overall wellness, social emotional development, and cognitive skills, are becoming more difficult for families to attain as they're struggling through mealtimes together. So I'm going to pass this off to Jess now, and she's going to talk about picky eating.
All right. Hi, everybody. So you'll see the question posed. We'd love to hear your responses. How do you define a typically picky child versus a child with a feeding difficulty or a feeding disorder?
Problems with weight gain, question mark?
Mm-hmm.
And folks are typing in, so it'll be just a second, Jeff and Lauren. A picky child will eat. Picky might get in the way of, food selections and gaining weight. Tiara says picky will eat sometimes and some things. Rosemary says picky eaters tend to have more purposeful behavior. Barbara says difficulty with breathing. Michelle says, would you also mind talking about how to help the picky eater families too? I think that means the families who are all the adults maybe. Michelle, if I didn't get that right, let me know. Christine and Allie in Suffolk say inconsistency with foods they will eat or not eat. And RBHA says sometimes they will eat it for a while and then stop. Tiara says when you have a disorder, there's a lot of crying and distress. Barbara says pocketing food in the cheek or food coming out of the mouth. Kathy says gagging or other more pronounced sensory responses. And let me check and see if we have a couple more people still typing, so I'll wait just another minute. Rosemary says sensory, GI, immune, and lack of experience with feeding disorders. Michelle clarified, I mean, though they don't have a disorder, families feel very frustrated and worried about picky eaters, and I'd love to offer any support in helping them eat more food.
Those are some really great points, and hopefully we'll be able to answer your question about how to support families who have children who are picky eaters. And we would love if you have any further questions, if anybody has further questions as we move along in the next topic, please feel free to type them in. Even if we can't see them, we will get to them. So let's take a look at the next slide. And it's another question for everybody. And Corey, if you can help with the best tool, I think it's the polling tool.
Sure. Sure, I would be happy to be able to answer to the question that you see on screen. Right under your name, you will see 4 small squares. The one furthest to the right has a small letter A, and when you drop on that, you will get the answers, the drop downs. So then you'll see that Jess and Lauren have posed 4 responses, and you pick the response. And Jess and Lauren, people are typing in now, so it'll take just a minute.
Okay, great.
And Jeannie, if you can pull the poll for us. Jess and Lauren, we had for A, we had 2 out of 3, 6% picked A, 15% picked B, 6% picked C, and 6% picked D. So again, the highest response was B.
B, okay, and that's actually correct. So it's about 19% of caregivers describe their 4 to 6 month old as picky, which I just think is so fascinating because that's really when kids are just starting to get introduced to new foods. So it's hard, for me it would be hard to judge if it's picky or not, but we'll talk more about that. So let's take a look at the next slide and the next question, and again it's going to be another poll. So in asking caregivers if they would describe their 19 to 24-month-old as a picky eater, what percentage would you guess agree with this statement?
Lots of answers still coming in, Jess and Lauren, so I'll wait just a minute. Yep. Okay, Jeannie, if you can pull the poll for us, please. All right, we had nobody respond A and B. 14% responded C, and 35% responded D.
Wow. So and it's so the answer is actually probably somewhere between C and D, but it's about 50% of caregivers describe their child as picky at some point between the ages of 19 and 24 months. And sort of as a spontaneous chat, what are some of the reasons why you think that more parents at 19 to 24 months would describe their child as picky? If anybody has any ideas.
So again, if you can answer that question in chat, and I'll be sure and help Lauren and Jeff know what you're typing. RBHA, oops, now they came really fast. Hang on just a second. RBHA says they become more independent and say no more often. Kira says because children now start to express themselves. Goochland Paladin says kids are developing free will. Barbara says because they're throwing food off the plate. Dana suggests children are becoming more vocal, so they are louder in their no to veggie. Kathy suggests children are showing more independence or asserting it more, which parents may interpret as picky eating. Rosemary says children should be more experienced with eating and eating a variety of textures and flavors, and they want more control. Dina says they're more independent and love no.
Yes, absolutely. I agree with every one of those statements, and I think you guys all know this innately that between the ages of 18 months and older that kids really do want to assert their independence, and that often manifests itself during meal times. So let's check out the next slide and talk a little bit about this picky eating phenomenon. So as we kind of talked about half of the toddlers that we see are going to go through some streak of independence with their eating, which parents may interpret as picky eating. But just in terms of food preferences in general, we know that food preferences are not innate. So even though kids get, or babies start to get taste of food even prenatally through amniotic fluid, and if they are nursing, they're getting lots of different flavors through breast milk, they still need to have lots of true experiences with food before they're able to truly develop a preference. And preferences are really driven by the parents and the caregivers' attitudes about food, how often they're offering foods, how their parents and caregivers understanding about what's appropriate for their babies and their toddlers' diets. Also looking at intake patterns, what the parent and the caregivers think are appropriate intake patterns. And truly it's all about food exposure and how children are exposed to food and how their parents are responding when they're reacting in different ways to new foods. So let's take a look at the next slide, which is another poll. So how many times do you think a child needs to be exposed to a specific food before they add it to their diet?
Folks are still casting their votes.
Okay.
Lots of votes coming in. Let's see. Okay, Jeannie, if you can put our poll up, please. Okay, nobody responded A. 5% responded B. 11% responded C. And 29% responded D.
All right. So yeah, the answer is D. A child needs to be exposed at least between 10 to 30 times before they're going to decide whether they really like a food or not. And this information has been found and reaffirmed across studies, and I think our pediatricians are now even more supportive of giving this information to parents. But it still can be kind of daunting for most of our parents if their kids are having strong reactions and they're feeling defeated and may not want to offer the foods again. So let's take a look at the next slide. So most often, parents offer a food between 3 to 5 times before they decided that their child didn't like it. So for most of our kids, that's not going to be enough time. 25% of caregivers offer food only 1 to 2 times before deciding that their child didn't like it. And only 6 to 9% of caregivers offered their child food 6 to 10 times. So again, the majority of parents are offering a food 5 times or less before deciding that their child doesn't like it. And as we're going to talk about, it's also how you offer foods to encourage kids to explore it on their own. So let's take a look at the next slide. So one thing that we know is that when we try to entice our kids to eat a food, they are going to be less likely to eat it again versus when they're allowed to try it on their own. Just this morning I had a visit with a family, and the mom was sharing that she was trying to get her child, who's 2.5, to take 2 more bites of yogurt. And she was saying, oh, if you take 4 bites of yogurt, we'll get to go play outside. And he just wouldn't do it. So she finally gave up and said, well, okay, if you're full, then you can clear your plate and take your bowl to the kitchen. And as he's walking to the kitchen, he decides he's going to take 2 bites of yogurt before he puts it in the sink. And I think that was such an eye-opening moment for this mom, because it didn't matter how much she was trying to entice him with his favorite activity, that it wasn't until he decided he was going to do it on his own before he actually took the bite. So let's take a look at the next slide. So of course, as you all already know, oh, sorry, go ahead.
Listen, Lauren, there's a question that's right here, so I'm going to jump in.
Sure, of course.
Harrisonburg Rockingham is asking, is it the same amount of trials for textures as it is for taste?
Oh, that is a really good question. So that's a great question. I would say that texture is a little bit different because there might be some oral motor differences in their ability to manage textures. So while I would encourage you as the interventionist to encourage the family to offer a variety of textures and continue to try new textures, you also do want to assess for oral motor concerns that would limit the child's ability to safely eat those textures.
Yeah, I think that's a good point. And the example that I can think of is a family I'm working with and this mom would really like for her child to eat green beans. And when we look at her oral motor abilities, she's most comfortable with purees and dissolvable solids like crackers. And so, you know, when mom puts green beans on her plate, with true green beans, she understands that she may not eat them, but having them on her plate to touch and to feel, in addition to having her pureed green beans, she's getting the flavor exposure and she's getting the touch exposure in terms of touching the green beans. But she understands that at this point she may not be super successful with chewing the green beans. She might still be spitting more, which is a part of typical chewing development. And so it's just also educating parents about typical oral motor development and supporting them and offering foods that are developmentally appropriate, while at the same time exposing them to foods that the parent wants them to eat. Does that help to answer that question?
I'll wait to see if that person responded, but there is a subsequent question from Michelle. She says, can you speak to how to work with families who have low income and cannot afford to have so many tries with the same food? And do the trials need to be consecutive?
Yeah, that's a really great question. We work in our area with actually many low-income families. So although Fairfax is a very wealthy county, we have a high proportion of families that are low income. I would say that the majority of our low-income families receive some sort of support through WIC, and we encourage them to work with WIC in terms of, you know, if they're at the stage where they're still getting like supplemental baby food, that they're getting and that they're able to get enough jars of food. It does get trickier as they get older, because I know for many families the subsidies for food can get cut, and having access especially to fresh fruits and vegetables and meats becomes more challenging for families as the child gets older. I would say that food waste is a real concern for families, and so it's really looking at the resources of the family and making appropriate recommendations. But that also might be helping the family get connected. If you know that there's a greater food need, getting them connected with local food banks and organizations to support their families' ability to eat enough food and to provide for their kids. But this is a question we get a lot. So, you know, we're really going to base it on we're really going to make our recommendations based on what the family has. And so, you know, instead of offering one food that the child will eat and 3 foods the child won't eat, it might be saying, you know what, let's offer them one food that you know they'll eat, and if the parent's going to be eating a different food, also offering a small portion to the child just so they get that exposure. But you're certainly going to tailor your recommendations to the resources available for the family.
And I think those are all the questions you have right now. Harrisonburg Rockingham did indicate that you answered their questions, so thank you.
Okay, of course. So when we think about the role of development, we know again that children are very independent at this age, but we also know that there is some degree of food neophobia, so fear of new foods, that is innate in all of us. And there's some research to suggest this might be a protective function from way back in caveman days when we wanted to be sure food was safe. We would use smell or how a food looked before we would eat it because it might kill us. So a tiny bit of that is still left over, and we sort of see that in our kids. We might see that in ourselves if anybody has experience, you know, going through like the fish market or going through Chinatown and seeing foods or smelling foods you're not used to, your initial reaction might be strongly opposed to the idea of trying a new food, but you know, because we're grown-ups, we can cognitively think about what are the steps we need to take to eat it. But we know for our little guys, they don't have those cognitive steps, and so we have to give them a supportive place where they can safely explore and experience new foods on their own. So let's check out the next slide. We want to talk just a little bit on regulation, because this is a question that we often get asked. And for the majority of kids, they will be able to regulate their intake and will be able to eat enough to grow and thrive. I think oftentimes children with developmental disabilities, so children that we see in our program, may not have that ability. So even though it's a small percentage of the general population, and I think many of our community pediatricians will say, oh, they'll eat, don't worry. We do know there are kids that won't eat. And again, the same mom this morning with the yogurt, she said, I know my kid well enough to know that if I don't feed him on a schedule, he won't eat. So we're going to talk a little bit in a little while about why scheduling meal times can be so important for our kids. So let's move on to the next slide and start talking about the division of responsibility in eating. And this comes directly from the work of Ellen Satter, who is a social worker who has specialized in working with kids with feeding disorders. So the big message that she sends to families is that the parent chooses what to offer, so offering foods that are safe and appropriate, and offering it in a positive way. And it's the child's responsibility to decide how much or even whether they want to eat. And so children who are consistently frustrated around feedings are going to have a negative reaction. So we know that if there's any kind of anxiety around mealtimes, what anxiety does is actually decrease appetite and decrease hunger. And then kids start to associate feeling hungry with being anxious, and then they actually don't get hungry. So it can become a pretty negative cycle if we don't intervene and support families to, as much as possible, be calm and positive. So let's talk about some general strategies that you can share with families, especially for our families to help them get on a schedule and to promote satiation and feeling hungry. One of the works that Lauren and I really like is from Dr. Irene Chator, who is a psychiatrist up here at Children's National Medical Center, and she runs the feeding program up here. She has a lot of family-friendly material, and the book that we both really enjoy is When a Child Won't Eat or Eats Too Much. And in this book, she talks about the importance of establishing meal schedules. So her recommendations, and again, this is sort of, if you're talking about a standard, this would be the gold standard, may not be appropriate for every family. But it's 3 meals and 2 snacks, only offering water in between meals, limiting meals to 20 to 30 minutes, and setting the expectation that the child remain at the table until the parents are full. Because sometimes our kids, especially with low hunger drive, they can't recognize whether they're hungry or they're full. And having the parents set that can be helpful. It's a very physical, visual prompt. Mommy and daddy are still eating, so we're all going to sit at the table until mommy and daddy are full. The other the recommendation that she makes is that you only want to offer 3 to 4 foods per meal, but you always want to offer something the child will eat, because again, you want the mealtime to be positive. So you still want to expose them to the new foods while at the same time offering them a food that they can eat. All right, so let's look at the next slide, and we want to open up a chat to you. So what is your go-to strategy that you share as clinicians or providers with families who are struggling with mealtime behaviors? So you can go ahead and let us know what you like to share with families.
No grazing from Christine and Allie. Lots of folks are typing. Sit in a chair or at the table, no wandering around. Everyone eating together. Rosemary says family meals, try to avoid grazing throughout the day. Be patient. Wendy says, do away with pressure for intake and increase encouragement to touch and play with food at the table. Sit at the table. Don't fill up on milk or juice from Harrisonburg. Goochland says give them some control and let them make a choice. Stephanie says no full of milk sippy cups or bottles all day. Make meal times fun. Let's see. Quality versus quantity. Anna says structured meal times. Tiara says decrease juice. Hide veggies. I think that means like hide veggies in the meals. Harrisonburg says turn the TV off so there's no distractions. And I think those are all that have come in this far. Oh, yeah. Yep, that's it. But one more, it's important to be respectful of the family's routine. I think that's it, Jess and Lauren. I'm wondering if we're having technical difficulties again. If you all can type in chat, if you all can hear me, that would be helpful. I think we may have lost Lauren and Jess, so if you can just let me know if you guys can still hear me. We can. Yes, yes, yes. Okay, all of our participants are still on the call. So just hang tight a second, and we'll wait for Lauren and Jess to reconnect with us. Hello, it's Corey. Lauren and Jess. Okay, I'm going to wait just another minute. Feel free to chat amongst yourselves.
Corey, this is Dina, and I guess I am having a little bit of a flashback to thinking about this with my young children and routines and activities that we did as we explored new foods.
Okay, hello.
Hi.
Hello, are you guys back?
We are back. I'm sorry. We think we had a power surge, and so we briefly lost our connection, but we're back.
I just have to tell you guys that you are pros at this. Technology, and you're doing a great job, and everybody is still right where you left them. So, Lauren and Jess, if you need me to kind of get you back in the groove with what people had said to your, what is your go-to strategy?
Yeah, and I think that the feedback that we had written down was great. So what we had gotten before we lost our connection was no grazing, parents being patient, doing away with the focus on intake, rather the interactions, that everyone's eating together at the table, to limit milk or juice because that can fill a child up. So let us know if there's additional information that we've missed.
There has been a question, how do you handle when families don't want to increase the choices of or the variety of foods? This person's remembering families who were fine with chicken, only eating chicken nuggets.
So if the family is fine with just eating chicken nuggets, if there are no concerns with growth or development, we just sort of leave it be. There a lot of families have strong preferences and are okay if their kids are eating, and even though we may not be okay with it, if the family is okay with it, then we just sort of leave it be. But you can always leave the door open and just say, hey, listen, as part of my job, if you're interested in expanding food choices, just let me know and we can always talk about it. So that's sort of how we handle it on our end.
That's great. Thank you, guys. And I think that's all the comments that have shown up. So whenever you're
okay. So really just some additional information, and again, this comes from Dr. Shutor, and you guys really touched on it already, is that for the adults, for the parents and caregivers at the table, that they're engaging with their child, but again, the focus is not on the food intake. The focus should be on the interaction with the people at the table, and that if the child is playing with the food, and again, every family is going to be a little bit different on what that means or what that looks like, but if it's a positive activity for the family and for the child, then it's positive for everyone, and that we want children to be allowed to self-feed, and that parents be present at the table but not intervening. So of course no force feeding. And with the child with low hunger drive, which again, as I think Lauren and I often see this, offering very small portions can be helpful because the child doesn't get visually overwhelmed with what's on their plate and can also feel success when they finish the portion that's on their plate. And that what we find is then kids over time then develop the ability to ask for more as they start to recognize their own feelings of hunger. So let's look at the next slide, which should be two little babies on the floor. So I believe this is going to be another poll. So what to avoid during meal times. So let us know what you think.
And folks are putting their answers in now.
Okay.
Okay, Jeannie, if you can put the poll results. You had 2% who said A, and all of the other respondees said E.
Okay, and that's right. The answer is E, all of the above. So truly what we want during our meal times is the focus on the family and not on the food. I think, all of us have walked into a family's home where they do use the iPad or TV during meal times in order to get the food in, or they're using food as a reward. They're coaxing or force feeding, and we can't just walk in and say, stop what you're doing, that's not right, or that's not going to help your child. We really have to meet the family where they are, and with developing a relationship with the parents, as Lauren mentioned earlier, you're going to help families to recognize that over time the TV and the iPad may not continue to help their kids to eat more. It's going to become more of a distraction, and that you may find that, again, the coaxing and the forcing is going to develop more negative behaviors. This can be challenging for our families, especially if there is concern for growth, for weight gain. But again, it's meeting the family where they are, and with positive strategies and through coaching, we can get families to move away from these mealtime distractions.
There has been a question posted, actually I think two, but I'm going to hit this one because I think it's right about this slide. Would you mind sharing the research I can present to families about these things to avoid? That's from Michelle, and we can definitely make a note if Jeannie or Dana or Dina can help with that, but just know that that has been a request.
Okay, great. Well, and when you receive that invitation today, there should be a link for additional handouts and resources. So some of that information is going to be in there, and you're welcome to tailor it to the families that you're working with. In our resources, we have a bibliography of research and books available to both clinicians and families that talk about positive mealtime strategies and what to avoid during meal times. But if there's additional information that you would like or you can't find, our emails are available, and you can always reach out to us directly if you're having trouble finding these resources.
Thanks, and you all can see in chat that Jeannie also put the link again to the list of resources and references you received with your notification today. So if you want to click on that link, you'll be able to get that information as well.
Fantastic. And I think you said, is there an additional question that we can answer?
Oh, yes, hang on just a second. It was from Rosemary, and she asked, how about families who are willing to try new foods, but the 2-year-old refuses?
That is a great question. I think it's about repeated exposure in a very positive way. You know that sometimes families feel more comfortable with trying new foods with you present as the clinician. And so sometimes when I'm working with families, I'll have, they'll want to try new food, but they don't want to do it on their own because they're afraid they're going to revert back to their old habits in terms of coaxing or trying to use another food item as a reward. So then we'll have a meal together with whatever the new food item is, and that as a clinician I can model an interaction style for the parents, and then when the parents are then trying it with their child, I can then provide feedback and offer additional modeling or strategies for the family. Because we want to build the confidence up of the caregiver because they're with the child every day. So I'm going to move on to the next slide, and I'm going to hand it back over to Lauren so she can sort of wrap up our presentation and offer some closing thoughts.
So we want to move on to the next slide and just quickly talk about what the goals of feeding intervention can be within early intervention services. Research has shown that the most effective parent and caregiver training programs include strategies that teach parents to positively interact with their children and praise the desired behaviors, such as sitting at the table or feeding themselves. Teaching effective emotional communication skills, such as active listening, reduction of negative communication, encouraging supporting caregiver practice within the sessions, which is key to the coaching approach that we use, and focusing on improving all aspects of feeding development, including successful and independent mealtime participation, which, as we've stressed throughout this whole presentation, does not have to include eating. Moving on to the last slide, we do know that we have to assess progress somehow. We kind of think about progress assessed in 2 different ways. One way is in quantitative gains, so the increase in volume of foods consumed at a meal, and the decrease of the inappropriate behaviors such as throwing, crying, getting out of the seat. But we can also assess progress through the qualitative gains that are made, such as the child's enjoyment of the meal, their intrinsic motivation to eat, the quality of mealtime interactions within the family, and the parent's report of positive family mealtime. So just looking at this last page, this is our all done slide, and this is actually my nephew asleep after a meal. We just want to thank you so much for your participation in today's webinar, and I think we're pretty much out of time, but if there's any more questions, we'd be happy to take them before we wrap up.
Thanks, Lauren and Jess. Folks are writing great job. I too want to second that you guys pulled this off given all of the technology. So thank you so much. Folks who are on the phone, if you do have any more questions, feel free. We can pull questions from the chat, and we will leave that open for another minute and get those to Lauren and Jess if you need follow through. And Jess and Lauren, you're getting lots of thank you comments and well done and great job. So folks are signing off with that.
Thank you, Corey, for your support.
Oh, no Awesome. Thank you
Yeah.
all for joining. Look forward to seeing you in December. Thanks. Bye-bye.
Thank you.